This program is brought to you by Emory University.
Thank you, and good morning, everyone, for joining. It is my pleasure today to introduce a friend and one of our own, Dr. Michael McDaniel. I have known Michael for 20 years, and we were just talking about how time flies. He's currently the director of the Cath Lab at Grady, associate professor here at Emory. He went to undergrad at UNC Chapel Hill and Medical College of Georgia with me. And then we both came to Emory for a fellowship, and Mike decided to go into interventional and completely opposite track of mine. But, you know, he's always been very helpful answering all my interventional questions. He's on the National Committee for the Pulmonary Embolus Response Team Consortium. He's been involved in that since 2015. He's been on the Protocol Committee, the Nominations Committee, and now on the Board of Directors. He writes questions for ACC SAP, is also on ACS committees, lots of committees for Emory Healthcare. I didn't even know that there were so many committees that Mike was involved in. He has really, you know, under his sort of leadership, Grady STEMI program has received gold recognition by American Heart Association Quality Award, which is amazing. He's a Rising Star Teaching Award, does lots of conferences and lectures for fellows and med students. He's on the editorial board of Clinical Cardiology and associate editor of JACC CV Interventions. When I needed a speaker for April for today, I just had to send one email to Mike, and within a few minutes, you know, without problems, sure, I'll be happy to talk. So thank you, Mike, for presenting today on catheter-directed therapies for PE.
Thank you, Pooja. I really appreciate it. So these are my disclosures. So I thought we should probably start with a case. This kind of illustrates, I think, a lot of what we're going to be talking about today in this discussion with pulmonary embolism. So this is a 41-year-old male who we saw with really no significant past medical history, who presents to the emergency department with acute shortness of breath and syncope. He was walking to the store, passed out twice, struck his face, actually came into Grady as a trauma. And you can see when he came in, actually his blood pressure is on the low side. He's hypotensive, he's tachycardic, tachypnic, hypoxic. So obviously acute pulmonary embolism is on the differential. His repeat blood pressure just a few minutes later normalizes, but he's still tachycardic. They get a troponin, it's elevated, it's lactic acid's normal. They get a CT scan, and you can see here in the distal right main PA, a large thrombus burden in the distal right main PA, and then there's a saddle component that comes back with extension into the left main PA. And one of the most important things to look at on these CT scans, the RV. RV is significantly enlarged compared to the LV here. And so the real question is, what is the best management? We're going to try to go through some of these things, talk about the data, because there's a lot of options for patients like this. You could just put them on anticoagulation alone, watch them, and then give them rescue thrombolysis if things get worse. You could go ahead and give full dose systemic thrombolysis or half dose systemic thrombolysis, catheter-directed thrombolytics. You can perform embolectomy either surgically or in the catheter base, or you can put a filter in. So to answer this question, I think and we'll come back to this case at the end, wanted to really, I think, anchor with the risk stratification. So it's really impossible to talk about how to manage a patient without first talking about their risk stratification. And so a few words about risk stratification, and for the fellows, for the residents, it's really important when you write the problem in the chart, acute pulmonary embolism, that you anchor it to a risk stratification, that you put them into at least one of these buckets. So the first bucket is massive PE or high risk PE. And I see this terminology get used incorrectly all the time. Massive PE does not mean a massive amount of clot or a massive, massively large pulmonary embolism. This is defined as shock. So someone who has sustained hypotension comes in needing inotropes or has CPR, cardiac arrest. So that would be on the one end of the spectrum, the massive, the high risk. On the very opposite end of this patient is low risk acute PE. And this is patients who have normal blood pressure, no RV dysfunction, and no myocardial necrosis. These are very low risk patients, could usually be just treated with anticoagulation alone. The more interesting group, and I guess that this patient would fall into this, is somebody who would be determined to be submassive or intermediate risk. This is somebody who ends up normotensive, as this patient was, does have RV dysfunction and myocardial necrosis. And so this group, we usually will make this determination based first on the CT scan, as almost all of our patients today will have a CT-PE protocol. And so it's really important to look at that RV size on that initial CT. And if it's elevated, if the RV is starting to approach the size of the LV, or it becomes larger, that's a enlarged RV, and we can confirm this with an echocardiogram. Now, the European guidelines would suggest that we break down this submassive group into two groups. Of those that are high risk submassive, and this would be the group that has RV dysfunction and positive troponins, and this would be differentiated from those that are low risk submassive, where you may have RV dysfunction, but the biomarkers are negative. And the reason that the European guidelines use this stratification is that the combination of these two together are more predictive of death. So this is a nice registry, over 1,200 patients that are stable. So the blood pressures are normal, coming with acute PE. And you can see that if your troponin is normal and your RV is normal, that your in-hospital risk of death from an acute PE is very, very low. But as RVs become enlarged, mortality goes up. As troponins become elevated, mortality goes up. And such the combination of a high troponin and RV enlargement, at least in this registry, was about 8% risk of in-hospital death. And just to put that in perspective, that's twice the mortality, in-hospital mortality for STEMI. So, STEMI gets all this attention. We have tons of literature and tons of trials. Yet, high-risk submassive pulmonary embolism has probably twice the in-hospital mortality, but yet a lot of a paucity of data, as we'll show. And so it's important for us to focus on this group here. Now, there's other ways to risk stratify this. We can't go through all the different risk stratification mechanisms, but one of the other, I think, really important biomarkers to pay attention to, and is starting to get more attention, is lactic acid. And so when you look at those that have RV dysfunction and positive troponins, they do have a high risk of mortality or hemodynamic collapse in hospital. But the combination of RV dysfunction, positive troponin, and lactic acid, that through those three things together, that risk becomes almost 20% for either mortality or for hemodynamic collapse. So this in particular is a really important group for us to think about and worry about for our treatment. So before we get into some of the catheter therapies, I think the real question that we have to start to answer is, what do we know about some of our traditional therapies when it comes to treating this intermediate group, such as our patient that we started with, the submassive pulmonary embolism group, especially the high risk. So what do we know about anticoagulation, and what do we know about systemic thrombolysis? So unfortunately, when it comes to improving symptoms, we don't have a lot of data. We think it makes intuitive sense that if we were to give systemic lytics and try to break up the clot and relieve the obstruction and make the RVs better, that our patients should feel better faster and feel better down the road. This trial attempted to try to answer that question by Dr. Klein, but they set out to randomize 200 patients with submassive PE to anticoagulation or full dose lysis, but they ended up having to stop early with only 83 patients. So this is the largest trial looking at symptom benefit, but unfortunately it was stopped early, and so a pretty small trial. But when you look at the composite of death, recurrent PE, poor functional status, you can see that lytics did improve outcomes quite considerably compared to anticoagulation with a pretty large absolute benefit and a number needed to treat that's actually quite small. And this was really driven by making people feel better, improving their functional class, their New York Heart class, or their 6-minute walk at follow-up. So I think that this is a hypothesis generating study. It does suggest that perhaps being aggressive with patients like this and improving the obstruction earlier will make patients feel better down the road. But again, this data is not large enough for us to be definitive, and we clearly need much, much better data, more randomized trials to look at this question. But there is at least a hypothesis that we could be making people feel better. But I think the real problem and what most people get most worried about is that the acute afterload of an acute pulmonary embolism leads to pulmonary pressures that go up, and this leads to RV failure and can ultimately result in this shock spiral and death. And so I think one of the main reasons that a lot of people get interested in treating these patients is to try to interrupt this shock spiral. And the question is, do we have data that interruption of this shock spiral will improve these outcomes? And the answer is, I think we do. So the best data comes from the Pythos trial. And we're going to talk a little bit more about the Pythos group when we get to catheter therapies. So I want you to remember the Pythos group here, because they really did a nice job. And this is probably the best study in this space of over 1,000 patients, high risk submassive PE, RV dysfunction, positive troponin, randomized to anticoagulation or full dose thrombolytics. And what was found is that if you got the full dose thrombolytics, that there was less hemodynamic collapse compared to anticoagulation, less need for CPR, catecholamines, pressors, and death. And the number needed to treat was modest, but I think reasonable at 29. So it does seem that compared to just a more conservative anticoagulation course, that systemic lytics in the full dose can interrupt this shock spiral. And if you put all the data that are from randomized trials, so this is almost 2,000 patients, almost 1,800 patients from 8 randomized trials, that in total, when you look at mortality with systemic lytics versus a more conservative anticoagulation approach, that there is probably a significant reduction in mortality by treating patients aggressively with systemic lysis. Now, when you look at this, it's while statistically significant, the absolute differences in mortality are quite modest, especially in the randomized data. And so your number needed to treat is quite modest at 65. So there is some questions about the clinical significance of such a treatment, but it does suggest that the data in total would suggest that we can interrupt this shock spiral. And if we do this, we could potentially improve the mortality for this population. The downside, the Achilles heel, and we all know this, is that when it comes to systemic thrombolytics, that it's really impaired by the high bleeding complications. When you look at major bleeding complications, much higher compared to anticoagulation alone, with very low numbers needed to harm, and the dreaded treatment of intracranial hemorrhage, somewhere between 1.5% to maybe as high as 3% with systemic thrombolysis. And so really, limits, I think, the benefit of using full dose systemic thrombolytics. Now, one of, I think, the interesting questions was maybe we have the wrong dose of systemic thrombolytics. So when we talk about full dose thrombolytics for the fellows, for the residents, what we mean is we're typically talking about 100 milligrams of alteplase. So if you were to go look at what the labeled on treatment FDA approved dose for systemic thrombolysis for acute pulmonary embolism, it would be 100 milligram dose. We would give this as a 10 milligram bolus over 10 minutes and then give the other 90 milligrams over 2 hours. So that would be a standard way of treating patients with full dose systemic thrombolysis. But others have looked and said maybe that's too much, and maybe a 50 milligram dose is all we need to do. So do that same strategy, but with just half the amount. And when you do that and you look at how patients fare, this was a modest sized trial of about 118 patients who were treated randomized to full or this half dose lytics. What you found is that half dose seemed to fare pretty well, that if you looked at the improvements in RV, the improvements of pulmonary pressures, the improvements in perfusion or obstruction, that the half dose seemed to do just as well as the full dose strategy. And at least in this trial, there was numerically less bleeding complications. So suggesting maybe you could have just as good an efficacy and maybe a little lower bleeding complications. So an intriguing idea that maybe our systemic lytic dose is the incorrect dose. And if we were giving it maybe lower, we would be getting better outcomes. Now, that safety of 50 milligrams, though, has been questioned. So when this has been looked at in larger registries, again, this isn't randomized data, so there's a lot of weaknesses in registries, but when they looked at this database of almost 4,000 patients and tried to match them and really look at the complications of bleeding, what we found is after adjustment that the systemic lytics group were having a lot of bleeding complications and not that different whether it was given in the full dose or a half dose. So I think while an intriguing hypothesis that a lesser dose could be a good strategy, there's still a lot of questions about the safety of a 50 milligram approach. And so when you take all this data together of anticoagulation and systemic lysis, I think what you kind of come to is that systemic lytics just seems to be too aggressive. And there are some benefits. It seems like that it will improve mortality, will interrupt the shock spiral, will reduce the risk for need for hemodynamic collapse, and probably improve symptoms, but it comes at such a high bleeding risk that it really impairs its ability to be used effectively. Whereas anticoagulation alone just doesn't seem to be enough, that it's associated with worse mortality and worse shock and worse symptoms. And so this is really the stage that was set for what we thought is a need for, newer therapies that kind of better balance the safety and efficacy of these two approaches. And so this is really what we're going to be talking about today, is these catheter-directed therapies. And so there's really two approaches that we want to go through. The first is catheter-directed thrombolytics or thrombolysis. So the idea behind catheter-directed thrombolysis, and it's not a one way of doing things. It's sort of an approach, and there's a lot of different ways to do this. But in general, we take small catheters, 5 to 6 French infusion catheters. These have side holes in there. We bring it up into the clot, into the pulmonary arteries, and then you drip in small amounts of TPA. And typically, a typical infusion would be about 1 milligram in an hour for about 20 hours. This is what some of the studies have done. So when you look at the TPA that's used in a typical catheter-directed lysis procedure, it would be about 20% of what would be considered the systemic dose, so 20%, 20 milligrams compared to 100 milligrams. And importantly, at a much, much lower rate, so about 10% the rate. So you're giving 10 to 20% of the amount of TPA at any given time in a catheter-directed lytic procedure that you would giving systemically. So you're really reducing that lytic, and so hopefully really reducing that complication rate. So the question is how does this stack up, or how does this work? So we looked at some of our data from our early experience with Emory, combined it with the group from Vanderbilt, and then really took a review of all the literature at the time. And this is all mainly observational trials. So we took all the data that was out there, and at that time it was almost 720 patients. And this includes our group, our data here from Emory. And when you looked at the improvement in RV pressures with catheter-directed lytics, that you could see that in the literature and these observational data, this isn't randomized, this is observational. So, there are some biases in this data, but you can see a pretty consistent message that you would get a very early significant improvement in pulmonary pressures. It makes sense. You're putting in these catheters, you're dripping in the TPA, it's breaking down the clot, and this is reducing the PA pressures. And then also from this data, what we were seeing is that we were seeing significant changes in the RV-LV ratio. So that within a day or two of the procedure, a very clear message and a very consistent message of a mean change in RV-LV ratio of about 0.34. I know for those who aren't used to looking at this number, what does this mean? This is the equivalent of taking an RV that's enlarged and then bringing it back to normal. And you're going to see this number is in line with some of the other data that I'm going to show you from some of the other treatment modalities. So I think what you could say in the observational data that from the published literature is it's not a lot of patients, but in total, you're getting close to 500,000 patients that you're getting a very consistent message of improving RV size and improving RV function and PA pressures. And we can do this with a pretty low complication rate. So we went through and we looked at all the complications in these series. And again, these are observational data, which tends to be a little bit different than randomized patients. And also just one thing that I noted going through looking at a lot of these initial series is that a lot of this data came from series of institutions where this was really their first experience. And for us at the Emory data that was in there, that was certainly the case, that this was really our first experience of that. And I can say that as time's gone on, I think our complication rates have gone down, and I'll show you some data to that later on. Importantly, when you looked at the complication rate, the dreaded complications really were quite minimal, especially that of intracranial hemorrhage. And so this is probably not a fair comparison, but since we don't have randomized data, I do want to just show you this data. And I know people would probably say this is not a fair way to do this. But if you take the meta-analysis that I showed you of the randomized data of anticoagulation and systemic lysis, and then compare this to our look of the observational data, what you can see is that major bleeding complications are lower than that of systemic thrombolysis and probably more of that of anticoagulation, and that makes sense. It is more than anticoagulation, but it's less than giving full dose. And so this data is at least in line with what you would think it would be, even if this is not a fair comparison. And this, I think, is interesting when you look at the intracranial hemorrhage rates that compared to systemic lytics in these randomized trials, that the incidence of intracranial hemorrhage is much lower than that with catheter-directed lytics than that of systemic lytics. Now, I think it's also important for us to remember that anticoagulation alone is not always risk-free, that you can get intracranial hemorrhage with just anticoagulation alone. And the catheter-directed lytics probably has a higher incidence of intracranial hemorrhage than that of anticoagulation, but relatively speaking, maybe not as high as that of systemic lytics. So again, kind of showing that perhaps this hypothesis that if we're given the TPA slower and lower and more focused and targeted in the pulmonary arteries, that you can get a better balance of safety and efficacy. And this is the mortality data. Again, this is not randomized data. This is a hypothesis only generation. But I think it's important just to show you this because this is the data that we have. Since we don't have randomized data, we have to just compare the data that we have compared to what's known out there. And when we look at the mortality in the submassive PE patients in our series, our observational data, and compared to that to the randomized data of anticoagulation and systemic thrombolysis, that it is lower mortality, at least numerically. And so the question is, and this is just a hypothesis, that maybe we're getting a better balance of safety and efficacy. It's more effective than just anticoagulation, but not as risky or as harmful as systemic thrombolysis. And so maybe better balancing safety and efficacy. Now, one of the interesting questions that comes up is, do you need the ultrasound? So most of these early data were with ultrasound, facilitated catheter-directed thrombolysis. And so there are some ultrasounds on these catheters, and there's a theoretical reason to think that the ultrasound would be beneficial, that the ultrasound breaks up the fibrin and makes it easier for the TPA to bind, and thus makes it theoretically more beneficial. So we set out to answer that question in the randomized trial, the Sunset PE trial. And this was recently published at Viva, is not yet, presented at Viva, not yet published, but I wanted to at least show you this data. This was a partnership with Pitt, University of Pittsburgh and Piedmont, and it took patients who were undergoing catheter lysis and randomized them to the ultrasound directed procedures versus the just standard catheters without ultrasound. So the only variable in this trial was really the use of ultrasound. Otherwise, everybody got treated the same. And this is, it may not be the biggest study. We don't, in cardiology, we're used to really large trials, but this is actually the largest trial of catheter therapy in acute PE, which is kind of sad because it's only 80 patients. And about a quarter of these patients were enrolled at Emory and Grady. And when you look at this group, it was a younger group, mostly high-risk submassive PE. Most patients had acute DVTs, and most of the patients got around 19, 20 milligrams of TPA. So pretty standard treatments in both groups. And when you looked at the outcomes, the improvements in the obstruction score, so how much clot got removed by these procedures, what you found is that there was really no difference, that the improvements with ultrasound assisted was the same as that of non-ultrasound, or what we called standard catheter-directed thrombolytics. So no real benefit to the ultrasound in relieving obstruction. And when you looked at RV-LV ratio changes, again, no real improvements with the ultrasound. In fact, there was actually numerically better without ultrasound. This may be slightly related to the higher RV-LV ratio size of the baseline, and not necessarily that this was better, but there were slight differences between those. But at least it was showing you that there was really not a lot of benefit to the ultrasound compared to the non-ultrasound. Well, why does this matter? Well, these ultrasound catheters are about 10 times more expensive than the non-ultrasound catheters, about $3,000 a catheter for these, whereas these are about $300 a catheter. So a real value to hospital systems and to society if the ultrasound is not necessary. So we thought that this was intriguing data, and currently trying to get it published. Importantly, when you looked at the safety, there was really no safety differences between with or without ultrasound. So really does kind of question whether we need to be using the ultrasound with our catheter-directed thrombolysis procedures. And when you look at this bleeding complication that we saw in our Sunset trial and compared it to what we saw in the analysis we did from the observational data, you can see that we were seeing lower major bleeding complications in Sunset. And I think that there are two reasons for that. One is that this is randomized data and a little bit closer to what to the populations of anticoagulation and systemic lytics from the randomized trials, whereas this is observational data, and observational data always tends to have a little bit higher acuity and worse outcomes. The other thing is, I think that this reflects improvements in the procedure over time. Many of these observational trials were the initial series of a lot of institutions, and with experience, I think that these procedures are getting safer. And certainly in our experience, that, and our anecdotal experience, that this kind of mirrors this. We're not seeing very high bleeding complications. So I show this because I think that the bleeding complications are higher than that of anticoagulation, but perhaps not that much higher in really carefully selected patients, the type of patients that would go into a randomized trial. Well, how does this compare to surgery? This is Brent Keeling in the operating room taking out a large thrombus from a patient with acute PE. And I show this because it's so impressive how big that clot is and how also impressive surgery is as a treatment. So Brent looked at the Emory experience and wanted to see how surgery compared to the catheter-directed lytic procedures. Now, this is not randomized. This is just completely observational data. This is some of our initial experience with the procedure, as well as, these are apples and oranges. The patients with surgery, treated surgically, are really different than the patients who are treated with catheters. But I show this because at least it shows you that mortality and transfusions are not that different. Obviously, length of stay if you get a surgery is much higher. And I don't think that this tells us one is better than the other or the other, should be used. What I think it tells us is that in a team-based approach where you have all these as options, surgery and catheter procedures, that together we can, try to individualize these treatments to the patients. And it's nice to have good options with good outcomes for our patients with multiple different strategies. And it would be nice to get a randomized trial somewhere down the road of surgery versus catheter lysis. We'll probably never see that trial. But because of that, this is really the only data that we have. Now I think catheter lysis is going to continue to improve. This is a Thromblex catheter. Instead of using a single arm catheter, this is sort of it creates a basket, and this has multiple side holes to give you much more contact with the TPA with the thrombus, and it also will expand as the thrombus is dissolved. So here's a patient where we put this in the right main PA, or we put a standard catheter in the left main PA, and you can see that this theoretically would give you much more contact with the clot and perhaps make this procedure more efficacious. And we're currently enrolling patients in the rescue study trying to look at the Thromblex catheter. So the treatment of catheter-directed thrombolysis is continuing to evolve, continuing to improve, and it'll be interesting to see how the data from this catheter looks. And really importantly, what's really exciting is we're going to finally get some randomized trial. In that Pythos study I showed you earlier, there's a partnership between the Pythos group and the PERT Consortium, and Boston Scientific is sponsoring a randomized trial of looking at ultrasound-assisted catheter-directed thrombolysis versus anticoagulation in submassive PE. And so this should be hopefully starting this year. And we hope that in the Emory system, we can really, and Emory and Grady really enroll very well for this very important trial. So shifting gears, catheter imbilectomy. This is the other interesting evolution in treatment of PE. There's a couple catheters on the market. Let me start with a patient example, a 30-year-old patient, morbidly obese female who had come to Grady with a trauma, had a pelvic fracture, and then presents back with acute shortness of breath. The blood pressure is normal, but it's tachycardic, tachypnic. The troponin's elevated. For the residents and fellows, you can see the S1, Q3, T3, and sinus tachycardia, suggestive of acute PE on the EKG. CT is done, and you can see a very large clot in the distal right main PA with a saddle extension, and not as much on the left side. And then when you come down and look at the RV is very enlarged compared to the LV. And when you get an echo, this is, I think, a pretty classic looking echo for somebody with acute submassive PE. Severe dilation of the RV, severe dysfunction of the RV with sparing of the apex. And this is the McConnell sign. So very classic acute PE signs. We took the patient to the cath lab. Here's a pigtail in the distal right main PA. And you can see this huge thrombus that's in the distal right main PA, nearly obstructive of the whole right lung. And when you do the hemodynamics, the PA pressures are elevated and the PA sats are low, suggesting a low output state near in cardiogenic shock, despite the blood pressure being normal. And And it really, I like to show this because it shows you how big these clots are, and it just sometimes feels wrong to be leaving these in and just putting patients on anticoagulation. So in this case, we took up an Inari FlowTriever catheter. This is a 20 French catheter in this case. This is what it looks like, 20 French catheter. There are discs. We don't use these as much, and it's really just an aspiration system that we hook up and generates a high degree of aspiration at the distal tip. And in this case here, we're able to suck out this clot from the distal right main PA with removal of the majority of the clot. And at the end of the case, the PA pressures have come back to normal, the PA saturations have increased, and the echo the next day looks markedly better compared to where we started before the procedure. So we now have some data on the use of this FlowTriever catheter. This is the FLAIR trial, which we were part of. Wissam was our site PI and one of the leading enrollers in this trial, looking at the Inari FlowTriever in patients with high-risk submassive. And what you can see is that the RV-LV ratio from baseline significantly improves by CT in the 24 to 48 hours after the procedure. And that's much more than what we would expect with just heparin alone. And really importantly, this is done with a very low complication rate, despite using 20, and now we're using 24 French size catheters. Despite the size of these catheters, really doing it with very low complications, no intracranial hemorrhage, no access site major bleeding, and very low risk of total adverse events. So pretty exciting data. This is small, but it's at least, this is early, but it's very intriguing. So the Inari followed this FLASH trial, the FLAIR trial with the FLASH trial, which is a prospective registry. And what I'm excited to say is that we've just finished the enrollment of 500 patients just this month, and led by Wissam. We were the leading recruitment for this trial out of Emory, Midtown, and Grady. And we haven't gotten a look at the whole data set yet, but they did give us a sneak peek of what this data looks like at the American Heart Scientific Session. So they looked at the first 214 patients from this registry. And the data is really, really encouraging. That if you look at access site complications, very low. And this is done with the procedure times are low, the blood loss is low, the hospital length of stay seem to be less than what you would think, and mortality quite low in this group of patients. And again, this is probably not fair to do, but when you compare the randomized data to the observational data with catheter lysis to this observational data with FlowTriever, you're seeing very low rates of mortality. So is this better balance of safety and efficacy compared to our other trials? Again, this is just hypothesis generating. I know this is probably not fair comparison, but since we don't have randomized data, this is really all we have. What we can say is that in the registries that it's showing consistent reductions in our PA pressures on table, immediate, and then by echo improvements in the RV size and function. So compared to what we are used to seeing with catheter-directed lytics, we're seeing similar improvements with embolectomy. And if you look, this is kind of a busy slide, but if you look at echoes at baseline, most people have bad echoes with severe or moderate RV dysfunction. And at follow-up, the echoes are mostly good with no or mild RV dysfunction. This shows us our trends in Emory and catheter-based therapies that over the last 6 to 7 years, that one, the amount of procedures we're doing is increasing, and there has been a shift from catheter-directed lytics into the more FlowTriever procedures. I think part of this is driven by the studies we've been involved in, but does really also show our enthusiasm for this technology. There's other areas that I think the FlowTriever may be interesting. This is the first case series looking at removal of right atrial clot in transit using the Inari FlowTriever device. Here are 2 cases that have been out of VA and Grady by Gautam Kumar and Rajesh Sachdeva. So this is really the first series published on right atrial clot in transit. And I think that we're going to see that this is an intriguing area because the procedure can be done very quickly and seems to be effective. And we're also getting new curves to the catheters that may make it even better for trying to abstract clot from the right atrium. So maybe a little bit faster than doing surgery and certainly faster than doing an angiovac, which takes a while for us to set up. There are other catheters out there. The Penumbra is another catheter. This is an 8 French catheter, uses a separator to try to help improve the suction. And what happens is you end up with a much more macerated clot when you use Penumbra. I'm actually surprised that these small catheters actually do anything, but it does actually suck out a lot of this clot in much more macerated form. I do worry that sometimes this could be macerated and embolized more distally. But it has been studied now and just recently published in JACC Intervention, the Extract PE trial, which we were a part of, looking at the Penumbra catheter. And you can see that similar to what Emory and catheter lytics has shown, that there's a significant improvement in the RV size and function. And this is done with a pretty low complication rate. So how this compares or how this should be used with compared to Emory or the FlowTriever or other procedures, we still need more information. And it is, in Penumbra is also innovating, and they have a 12 French system that's just been released. So a little bit a bigger device and a stronger vacuum. So we'll see how this compares. So finally, a word about massive PE, and then do want to open it up with some questions at the end. We know the standard of care for massive PE, those that are in shock, is to give systemic thrombolysis. This is the European guidelines, it's class 1. The chest guidelines also recommend this. It's the standard of care. But what's amazing when you look at this standard is that it's really based on a very small data set. When you look at the randomized trials that have looked at thrombolysis, it's only 254 patients that have been enrolled in all the trials over time. So we really don't have a huge data set for this standard of care to be based on. But the data that we do have does suggest that lytics are beneficial in reducing recurrent PE and death, but again, with very high major bleeding complications. So it is, I think, in this group, really important because mortality is so high to be aggressive. This was recently just published, and I thought an interesting trial because it really looks at the last 20 years, you know, and what's going on in massive PE. And this analysis shows that it's a little bit busy, but let me just walk you through this, that mortality has improved in high-risk PE, but it's not driven by those that are getting lytics. And if you look at the mortality of those who get lytics with massive PE, that it's been relatively stable over time and still quite high in the 40 to 50% range of mortality, even with lytics. But what's really important is that only 16% of patients with massive PE are getting lytics. So even if lytics are great, the standard of care, there still is a very high mortality and most patients aren't getting this treatment. And what the authors concluded was that this improvement in the last 2 decades in mortality is purely a reflection of the treatment of shock and cardiac arrest and does not reflect any advances in the treatment of acute PE. So I think it's a pretty depressing landscape that our only therapy is not usually used, still has high mortality, and is really, we're making no progress in this space. So it really is kind of setting us up for, or can we follow that same path that acute myocardial infarction and acute stroke has followed from a heparin era to a lytic era to an embolectomy era or interventional era. And I do think that I've been showing this slide for years now, but I think we're now starting to really get to a point where maybe the answer is we're ready to study this. This is data from that FLASH registry with Sam put together with some co-authors looking at a very small cohort, but a very sick cohort from FLASH, massive cardiogenic shock. And what you can see is immediately on the table that you will see improvements in the PA pressures, improvements in cardiac output index, blood pressure improvements, and heart rate improvements. So really suggesting maybe if we go to the cath lab and do an embolectomy, you can get immediate improvements. And now I'm really happy to say that the FLAME trial is now just starting. It's the treatment of use of FlowTriever in high-risk massive PE. So this is a registry study. It's not randomized, but this is really one of the first trials of massive PE. And I think it's going to be really exciting to see how FlowTriever looks compared to our other treatment modalities in patients who are the highest risk for these complications. So we've actually just been got our site initiation visit, and so we will be enrolling. So for you all out there, if you see a massive PE patient, please let us know. We got to get these patients into this trial. A brief role about filters. The bottom line, there's randomized data that filters in high-risk submassive PE don't seem to improve outcomes. There's only one randomized trial, about 400 patients, but it didn't seem to lead to much benefit. And the guidelines recommend against it, and the CHEST guidelines. So I think routine use of filters are something that's out of favor in acute PE. One last thing, because this comes up for all of us, whether you're part of the PE team or not, is what do you do with our anticoagulation? This is a big topic. We could spend a whole grand rounds on this alone, but I want to just show one piece of data or one little way of thinking about it. We know that if you have recurrent VTEs, if you have need for anticoagulation, that we just put patients on indefinite anticoagulation, and the NOACs are the preferred treatment, just like AFib and really all the other indications. We also know that provoked, if you have a real provoked event, or there's like a subsegmental, we may just do a short course. But the real question is, what happens to the majority of our patients? You've had your first non-provoked event. What do you do? And you'll see a lot of heterogeneity in the way that these patients are treated. But we now have two randomized trials that have looked at either aspirin or placebo versus full dose extended anticoagulation versus half dose anticoagulation, both with rivaroxaban and I'll show you with Eliquis. And what you see is that compared to aspirin or placebo, there is a much better benefit if you leave patients on anticoagulation, but there's a lot better safety if you reduce this dose to half dose. So after 6 months or so of anticoagulation, if you reduce the dose down to 10, you seem to prevent events and you prevent bleeding. And this, again, was seen with the apixaban data, again, if compared to placebo, that if you left patients on half dose apixaban, that you had really significant reductions in recurrent PE, and you did this with really no added safety signal. So I showed this because the European guidelines, and this is the way we started to move, is that if you have had a non-provoked event, it's now recommended to leave patients on anticoagulation indefinitely, but that this dose is the half dose. So another 2A indication to reduce this dose down to half dose. So in our treatment, after a full dose anticoagulation of 3 to 6 months, we're dropping our patients down to half dose and kind of leaving them on indefinitely until we get better data. So back to our example at the end that we started with at the beginning, and then we'll have some questions. Remember, our patient, high-risk submassive PE, saddle clot. We talked about all the different options that we could do for our patient. We activated the PERT team at Grady and discussed. I think you can make an argument for surgery. You can make an argument for all the different catheter-based therapies. You can make an argument for some of the medical therapies. We discussed these and ended up taking the patient to the cath lab. We performed an IVUS here of the distal right main PA. And so just to show you what it looks like from inside the pulmonary arteries, here is the distal right main PA. Here's the right PA thrombus down here, what you see on the CT scan. And then here's the saddle, coming back to the saddle here. Here's that thrombus in the saddle. So this is what it looks like from inside. The use of IVUS is interesting. Gautam and Rajesh have published the first use of this. I think that it's an interesting way to help us guide our treatments, see how much thrombus where we need to target, and you can theoretically do these cases without any contrast at all. So we took the 24 French Emory up and sucked the clot out of the right main PA. We then went up to the left side and used the 16 French Flowtriever and sucked this out of the left. The pressures went down from 35 down to normal at 23, and the cardiac output improved on the table. And the patient was admitted not to the ICU, but to the floor. And the next day, the echo from baseline had normalized, and the patient went home the following day on a NOAC. So really kind of showing that you can perhaps reduce length of stays, get patients out of the hospital quicker with such an approach, and a very interesting treatment. So, the idea of these pulmonary embolism response teams, I'm glad to say, has now been accepted in the European guidelines, a recommended way for treating patients. For those who have interest, I really ask you to, check out the PERT Consortium. This is the national group interested in acute PE. We are definitely heavily involved, founding members, Emory, Grady, trying to contribute data to the quality database to understand treatments of PE, and trying to better understand this process. If you're part of the PERT Consortium, we send out pertinent updates, which is reviews of the literature, so that you can stay up to date on, best treatments and optimal treatments. There's a ton of educational opportunity too. There's podcasts, there's webinars all the time, and a really a great group to be part of. So if you're interested in acute PE, please, talk to me, talk to Wissam, talk to Gautam, Rajesh, Charles Grotson, Brent Keeling. Brent's going to be the president of the PERT Consortium next year. So really a big opportunity to get involved, and we're interested. We've put together some practice guidelines for those that have interest in reading more about this. We've kind of put together a consensus algorithms and a practice guidelines. And so if you want to read more, and finally, I just wanted to finish and then take some questions, that really this all started at Emory with Ken Lieber. Ken, for those who may not know, Dr. Lieber, he was a pulmonologist at Midtown who really had a passion for the treatment of acute PE, and he grabbed a group of us together, 7 or 8 years ago, and really talked about how we got to combat acute PE. And really, he was the pulmonary embolism response team before PERT had been publicized. So just really important for us to remember Dr. Lieber and his contributions to the treatment of acute PE. So with that, I want to leave it up. I think we got a few minutes here for questions, and really thank you for letting me come here and talk about acute PE management.
Michael, thank you. That was absolutely fantastic, as expected. What a wonderful summary. And thank you for walking us through the data and really highlighting, what the current guidelines are. I was really surprised to see that with 254 patients, there was standard of care. So that was surprising. Well, I know there are going to be questions. We do have a few minutes. While audience is typing in questions in the chat, maybe I'll go ahead and ask you one. What is your experience with pregnant patients? So have you done these catheter-based things? Because it seems like that would be ideal in pregnancy.
Yeah, it's a great question. The answer is we've had a few cases, not enough to really have any, published series yet on this. That's a very difficult group, and the good news is for treatment of systemic lytics, whether you do it systemically or catheter based, the mothers tend to be pretty low bleeding risk. There is obviously the real concern is a risk to the babies. But there is data out there that can be done and with some safety, but you're right, the Inari, the FlowTriever catheter based treatments without any lytics are an attractive option for some of these patients and have been done. And hopefully with time we can build some experience and to let you know how they're doing. But anecdotally there have been reported successful cases with the procedure, as well as doing it with no anticoagulation. We've done this in a couple post-stroke patients who have had intracranial hemorrhages and then acute PEs. And normally when we do an Inari FlowTriever procedure, we will use full dose anticoagulation, but we've done a couple cases with zero anticoagulation. So the FlowTriever procedure can be done with theoretically with zero zero contrast and zero anticoagulation if need be.
Okay, thank you. There's a question from Dr. Taylor. How will we incorporate high sensitivity troponin in risk stratification of PE patients?
Oh no, that's a great question.
We need to talk on high sensitivity troponin.
Everyone will now be a high risk submassive PE. I don't know how that's, we may have to use more than one biomarker. And certainly we look at more than one biomarker even today. So BMP, troponin, and lactic acid, I think, are three really important biomarkers. And that in combination with the clinical picture, such as the blood pressure, heart rate, respiratory rate, that combination, I wish we had a simple way. And some people use the BOVA score, some people use the SPECI scores, but we don't have a real great way to break these down. But I do worry that the high sensitivity troponin will push, would push us to be, more concerned than maybe we need to be. But one of there's two reasons for us to treat patients with high risk submassive PE. One is to improve their early in-hospital risk, and that's driven by the troponins and the BMPs and the clinical. But there is another reason to treat these patients, and that's just to make them feel better. Not only feel better quicker, but also to feel better down the road. And that group is the most interesting question, because all of us, especially if you were young and we see patients in their 20s, 30s, 40s, and our goal in that group is, if you were that patient, you don't want to just survive hospitalization. You want to get back to your the same quality of life you had before your PE, and you want to do it quickly. And so I think another reason to treat these patients is to try to improve symptoms both quickly and down the road. We don't have that data that we do this, but I think that that's a real strong rationale, and we need data that looks at quality of life.
Thank you, Michael. There's a question from Dr. Searles. Is there a window for therapies in submassive PE?
Another great question, because the window of time is one when they present with the PE, but there's another point in time when the DVT, most of these probably started as a DVT. The typical data would say you have about a 14-day window if you're going to use lytics. But we do know that the more acute that the whole presentation, that usually if the DVT started and then the PE immediately occurs and all of that was within the first day or two, those patients have I think a more predictable response to thrombolysis. The other thing, so I think the earlier the better, but there is a 14-day window that most of the trials have allowed for, but obviously the earlier the better when you do a lytic-based strategy. When it comes to the Inari FlowTriever, we're not sure yet. In theory, you can take out that chronic clot, but it doesn't come as well through those catheters. So it depends upon how big they are. So if you have a really big chronic clot, it's just not going to come through even that 24 French catheter. And we see that in our experience, and I don't have a way to give you data, but anecdotally, it seems to work a lot better the more acute it is. And those acute clots tend to be jelly-like. If you were to take them out, it feels like grape jelly. And so when you're trying to suck that grape jelly through a big straw, it will come with enough pressure. But as it organizes and becomes a little bit more like a rock or a little bit more, fibrous, that has a harder time coming through the catheter. So better outcomes with earlier, and the longer we go, the less everything works other than surgery.
Wow. Thank you so much. We are past 8:30, so I will go ahead and close the conference. Thanks again, Michael. This was fantastic, and we learned a lot. For those of you who are on, we have 2 more of these left for the year, and don't forget to sign in to get your CME credit. Thank you.
The preceding program is copyrighted by Emory University.